everyone. Thank you very much for coming today for this fantastic meeting that has a great lineup. Excited to see so many friends for many years. And just a few housekeeping informations. I would like to remind everyone to stay on time, to respect the time. I would request from moderators to give 1 minute's notice to the speaker. And without a further ado, I would like to invite the first session, which is session on innovation. Moderators are Dr. Liu and Dr. Butarbush from Taiwan and Morocco, respectively, to take the podium. And as they are logging in or opening their microphones, I would like again to thank Professor Salman Sharif and Mehmet Zileli for their hard work over the past year as a chairman of committees and chairman of education committee. They did fantastic job and carried on the legacy that we established 4 years ago, and I hope next term committees are going to flourish even further. So Drs. Liu and Dr. Butarbush, please take the podium.
Thank you, Professor. We start with our first session on innovation session. I'm Liu, and I will be moderating this session with Dr. Majoba. We have 4 eminent speakers here. We will start with our first speaker, Professor Mirza Pojosti, who is a consultant neurosurgeon at the Department of Neurosurgery, University of Hospital Marburg, Germany. Who is also a fellow of the European Board of Neurological Surgery, and today he will speak to us on robotic surgery. Let us welcome Professor Mirza. 8 minutes. Prof.
Thank you.
Sorry, can I just request, Luis Baba is here, so I thought he was busy, but he's available. So Luis, can you say a few words? We'd appreciate that. He's our president-elect. Luis. Where did Luis go? Okay, you can carry on. Maybe I don't see him anymore. You can carry on and we can join, ask him to join later.
Prof. Mirza?
Please start, Mirza.
Yes, second.
Dr. Poiskic, can you start your presentation? We are all waiting.
Mirza, can you hear us? Mirza is frozen. Can we move on to the next talk and then?
He's saying he's joining. So he's joining in a minute.
Can we move on with the next speaker and Mirza can join later, please?
Yes, sir.
We move on to the next speaker. I call upon Dr. Majoba to introduce our next speaker, Professor Lim. It's okay. I think while waiting for Majoba, let us call upon our second speaker, a keynote speaker, Professor Kang, who is a Korean neurosurgeon, a famous sniper, from Korea who are recognized as pioneer in the field of minimal invasive surgery, particularly in his development of percutaneous stereoscopic lumbar decompression technique. And he also the president of Good Dr. Ten Spine Hospital in Korea. And everybody know him. I think the whole world know him, and he has known for his advanced work in endoscopic spine surgery. And today he will give us a keynote talk on endoscopic spine surgery. Let's welcome him, Professor Lim, please.
Hello.
Yes, we can hear you, Prof.
Okay. Sure. Bye. Okay. Can you hear me?
Yes, you may.
Okay.
Proceed.
Okay. Hello, everyone. My name is Lim, Korean neurosurgeon like you. Good evening. It's 9 o'clock in Korea. Thank you for having me today. Today, I would like to briefly introduce what kind of spine surgery is possible with endoscope for young neurosurgeon today. So in Korea, sorry. Okay. Okay. So as a development about preventive medicine in Korea, early 2000, total case of brain surgery and trauma case have been decreased. So neurosurgeon had to shift to spine surgery from the brain. So we had to focus on endoscope spine surgery. So endoscope spine surgery is the most commonly performed spine surgery in Korea and account for more than 70% of all spine surgery. So spine surgery is endoscope is led by neurosurgeon in Korea than the orthopedic spine surgery. And even the patient knows it's very familiar to searching internet what is the endoscope spine surgery. They are the patient want to get the endoscope spine surgery in Korea now. In 2016, so I made by myself a new endoscope system with the Maxima, the spine company is my disclose. And with the endoscope, we can do not only discectomy, we can do the foraminotomy or spinal canal decompression, but also the fusion surgery, lumbar, and HDF. So today I talk about this. And for young neurosurgeon, I think the endoscope spine surgery is not option, but must in the near future. That's why the young surgeons do not performing endoscope spine surgery. So the total case of the spine surgery will decrease. So let's look at the lumbar is the one level lumbar the stenosis and pre and post operative. So we can do the decompression. But you can see this can show no any damage of a facet joint, and the narrow space you can do bilateral decompression. So one level and the two levels, so two level like this, and using endoscope. But during the operation, its advantage could be the bleeding is very less, and the patient have stenosis and the left side disconation. So we have to decompress bilateral and then discectomy also. It's good indication for endoscope and 3 levels, one pre and post operative, 1, 2, 3. Right? With one skin port, we can do one skin port, we can do 3 level. It's a jumping technique. A jumping technique means first using same skin port, we can do 3 level, but have to the fasciotomy at each level, and then after that we have to insert the drain at each level to prevent hematoma. And the 4+ operation is a 4 level with one skin port, 4 level central decompression, and 2 level is foraminal stenosis. It's a 4+ operation. We can do with a 2 skin port, we can do 4 level and 4 level central and 2 level foraminal stenosis decompression. So about the fusion surgery, so our path the next speaker, Dr. Hyun-Sung Kim, will talk about this fusion surgery. Yes, and then I move to the cervical case. Cervical, we can do endoscope, we can do posterior decompression, spinal cord, and then anterior approach H-step endoscopy. So cervical myelopathy is another challenge for overcome as an endoscope spine surgeon. So usually the debate in the spine complex endless and the constant debate was anterior approach better, posterior approach better. Is what the debate. But we have another option is posterior endoscopic decompression and endoscopic H-depth. Anyway, the open surgery, the problem could be the detachment muscle and will leading to eventually patient will have a atrophy muscle and the kyphotic change postoperatively. And endoscopic spine was introduced in 2016. Our team before the 2016, my team was the 1 year laminoplasty case was 20, and the Microsoft H-step was more than 80 case. But the Microsoft H-step was replaced by endoscopic H-step, and the laminoplasty was no longer necessary because you can do endoscopic decompressions. So in case of myelopathy, need to check and dynamic MRI to know location of the pathology. This patient is the same. A patient that has posterior buckling ligament. Just that's why we had to remove this only, the posterior buckling ligament only. The first choice of cervical could be posterior decompression. With one skin port, we can do multiple level decompression. Full level decompression with one skin port, and then even the long level decompression, we can preserve posterior ligament complex. That's why the post-operative kyphot change is very less. And then also we can avoid the laminoplasty H-step can be avoided. So posterior approach we can do spinal canal decompression or foraminotomy. So we can do axial portion, sensory, motor root, and then causal root, the sensory part. Like this. And then one of indication could be the paracentral disc and post-operative we can do endoscopy, post-operative discectomy, and the foraminotomy also. Pre and post-operative, but we can preserve posterior ligament complex. That's why there is no any the instability post-operatively. Pre and post-operative, and then one level decompression like this, and the 3 level, 1, 2, 3, and then 3 level with one skin port. It's a sliding technique. 5, 6, 6, 7, and the 4, 5. That's why the laminoplasty was no longer necessary. It's 1, 2, 3 level for the spinal canal decompression. 3, 4, the 4, 5, it's 5 or 6. It's a sliding technique, okay? For spinal canal decompression from ipsilateral to lateral, contralateral side, and with one skin port you can do. So for slide technique, you can find my chapter in the textbook, 4 level also, but there is no any the kyphot change post-operative because we can prevent the damage of the preservable of the posterior ligament complex. And open surgery, we had to preserve fascia joint more than 50% to prevent the instability. But the endoscope, there is no any the damage of posterior ligament complex, so there is no any the instability. That's why, in case of the orthopedic case, the total sometimes it total remove of the fascia joint is not lead to the instability post-operatively. its advantage it could be, I think, endoscope post approach, we can preserve post ligament complex, very important to prevent the instability. It's about, let's move to anterior approach, the endoscope spine surgery. So a patient have the calcified disc, and we can do endoscopic anterior approach and discectomy, and you can insert the cage. Advantage endoscope HDF could be, endoscope the system will provide good visualization and will guarantee safety. And operation time, around 1 hour is enough, and the post-operative anterior soft tissue swelling is very less. So, the advantage of endoscope, like this. So approach is the same like open surgery between esophagus and the keratosis. And we will push the anterior organ to open site with the finger, and we can insert the needle and the serial dilator. And then we can use the endoscope system and the discectomy and then insert the cage. Like this. Small. This is the perimeter fascia. And then after remove the perimeter fascia, we can expose disc space, and using endoscope system, we can do the discectomy and then remove PLL. And under the endoscope view, we can insert cage, and then finally, we have to insert the drain to prevent hematoma. From the 2017, my case is 250, and the outcomes and cervical lateral, the corpse angle, the disc height was good, and then also the all 100% of the fusion rate is my paper. Like this, you can do midline corpectomy, central corpectomy. We can do the endoscopic discectomy and insert the cage like this. It's a video. We can remove the calcified disc, and then you can see dura position. And then before the insert the cage, we have to insert first like this holder, cage holder, and then under the endoscopic view, you can insert the cage. Like this.
Professor Lim.
Yeah. Yes.
Yeah,
Okay.
there's time's up.
Okay. I'll pass. Okay. So anyway, you can do the C1 to high cervical on the thoracic also. Too short. You can do the endoscopic, the IDM tumor also, like this. I'll pass. Thoracic, and in conclusion, endoscopic operation will guarantee passive return to the patient life, and we can change the indication about the method of surgery, and the total case of the fusion surgery has been decreased. And for young surgeon, it could be the new field for young surgeon who want to become the spine surgeon. So bone was the first to destroy the world, Dr. Haram has said also. So I direct to the young surgeon, let's crack the air and go out into the new world. Thank you.